Good evening, friends. This is a video, complete step-by-step procedure of IAOS Gen X EBOO, done for numerous conditions including performance enhancement. Gen X EBOO is a result of continuing innovation and improvisation and improvement in ultra pure EBOO system without renal. This will also be lesson 33 of the advanced molecular therapies course, which is an ongoing course where I share all the knowledge that I acquire and learn periodically. What matters in MAHT and EBOO? Total dose or concentration? This is a question that has been repeatedly asked by our course participants. This is a very interesting question as both points are interrelated. Dose and concentration of ozone. What is our aim in extracorporeal blood oxygen ozonization and major autohemotherapy? That is a fundamental question which a therapist has to keep in mind. 1. The total dose desired should be administered within the shortest period of time without any complications or side effects to the patient. This is the most important and critical aspect. As the subject is sitting or lying with a tourniquet, we can't run the procedure for hours as in olden times with dialysis machines. They all want the session to finish in 30 to 40 minutes, and in these 30 minutes, adequate doses of ozone should be administered. In India, there are no proper ozone machines. Aquarium bubblers and vegetable washers were sold as ozone machines and still are. And these machines cannot produce greater concentration than 40 micrograms per ml. And that is the status of ozone in India today. In such machines, the regulators start with 500 ml per minute of ozone or 500 liters of oxygen or half a liter as a minimum flow rate. At half a liter of oxygen at 40 micrograms per ml of ozone, it is totally unsuitable machine for EBOO. So, there is a spelling correction in the above slide. It is 500 ml per minute of ozone oxygen mix. The oxygen flow rate is at 500 ml per minute. This will cause agitation, frothing in the blood. Lower the oxygen flow, higher the concentration of ozone. So, when the concentration is high, the flow rates are going to be low. This is a standard principle of physics which has to be followed. Lower the oxygen flow, higher the concentration of ozone. So, if you are having 1/32 per liter, or 1/16 of a liter, 1/8 of a liter, the ozone concentration is obviously higher. Lower flow rates with high concentrations don't agitate or froth the blood when they diffuse or bubble directly into the blood with a near 100% ozone absorption. So, in IAOS EBOO, we do not use any ozone destroyers and the room does not smell of ozone. What actually matters is a per patient per session ozone dose, PPPS dosage, which is very critical, relevant and important. As per the latest IAOS studies, performance enhancement, post-chemo cancer rehab, viral infection, septicemia, etc., 1 microgram of ozone per ml of total circulating blood is the ideal dose. For someone with 4 liters of blood, the need is like 400,000 micrograms. And someone like me with 6.2 liters of circulating blood, even 700,000 micrograms total dosage per session is good. The first step is to take a 500 ml of saline bottle which is hung on a drip stand. The surgeon wears gloves. As we are not touching the syringe or needle, everything is sterile. The gloves are more for personal safety of the operating staff, and surgical gloves are not needed. A 5 ml syringe is taken. A thick needle is deployed, as this needle will later be used as an air vent for the heparinized saline solution. This is a 5000 micrograms per ml of heparin, 4 ml of the solution, making it 20,000 international units of heparin are drawn into the syringe. This is a real time video without any speeding up. We are now injecting the heparin, shaking the bottle to ensure the heparin is well dissolved. The patient is Dr. Giger, a physician from Thrissur who has come to experience EBOO and probably incorporate into his practice. He is an ozone therapist himself. The remaining 1 ml in the bottle, which amounts to 5000 international units, is diluted in 5 ml and kept aside for priming and emergency purposes or flushing the cannulae. Though 25,000 international units of heparin are kept ready and at hand, the actual amount of heparin used in one patient in a single session is only 5 to 6,000 international units, which is very, very less. The syringe is now kept ready. This is an EBOO flask, the IAOS Borosilicate glass bottle. This has got a stainless steel diffuser. The top end of the bottle is where the diffuser is attached. This has got 3 markings: a large circle, a small circle, and a plus marking. We now put a needle through the small circle and ensure that it is in the bottle. That will be for the waste. These are thick 16G needles. Next one is a needle that is put through the plus mark, and we shake the needle to ensure that the diffuser shakes so that the ozone comes to the bottom of the bottle and is bubbled. We can temporarily keep the bottle in the hanger while we prime the transfusion set. This is the Gen X EBOO set, which comes pre-sterile. These tubings are made out of medical grade silicone with no junctions. There are only 2 connectors, one that goes into the patient's body and one that goes into the bottle. In between, the patient's connector is also attached by a 3-way to heparin, so that heparin mixed with patient's blood is drawn into the EBOO flask. So, I have one spike to go into the heparin saline bottle, a bivalve to go into the patient, and a spike to go into the EBOO bottle. The nurse is now inserting the heparin transfusion set into the heparin saline bottle, which is primed. We open the heparinized saline and allow the same to travel into the bottle and travel into the set, transfusion set, and also prime the entire length of the tubings. As blood will be constantly pumped through the system, it is essential to ensure that we fill the entire tubing with this saline solution so that we do not face any coagulation issues or blockages during the procedure. So, we can see the gravity is allowing the heparinized saline to flow through both tubes. The heparinized saline is now closed. This spike of the donor tube enters through the big circle of the top portion of the bottle. Now we have to attach the two silicone tubes, one for the waste out and one for ozone in, to the two needles already attached to the bottle. It is preferable to do all the connections before we locate the vein. So, now we have two needles, one for the waste and one for ozone. So, the pipe into the waste port is now inserted. This needle goes into the small round on the top of the bottle, and the other end of the silicone tube goes into the waste bottle. Now, the next silicone tube is taken through which ozone will enter the bottle. Sometimes it may be extremely crowded and we may not be able to negotiate the tube into the needle. In such circumstances, it is better to remove the needle and push the tube in, or move the other connectors to the side to see that we have enough space to connect the needle into the ozone diffuser. In this case, we have elected to remove the needle, connect the silicone tube, and then push it back into the stainless steel diffuser and ensure that the needle is in the diffuser. The other end of the tube is connected to the ozone machine. We do not switch on the ozone machine. The recipient blood will eject or emerge from the bottom of the flask, and here the transfusion set is inserted. The other end of the transfusion set is connected to the air vent in the heparin bottle to keep the sterility. The bottom silicone tube also has a big round circle through which the recipient tube is inserted. The height of the ultraviolet irradiation chamber is adjusted, and now the system is primed and ready for beginning to start the procedure. We now test the perfusion pump. We must ensure that the blood is sucked from the patient, goes into the bottle and goes back into the patient. The direction can be changed. You can see now the pump is going in anti-clockwise and now it is going in clockwise direction. If it is moving in clockwise direction, it will take the blood from the patient, draw it into the bottle and take it back to the recipient site. The silicone donor tube has two red markings, and between the two red markings, the tube must be put into the perfusion pump. So, you have two red markings, it has to be introduced in between the two red markings. The pipes are adjusted to ensure that there are no crossovers and all connections are free and comfortable. Once everything is done and ready, the nurse will puncture the vein. We are just closing the heparin and seeing if the pump is functioning, and if the heparinized saline is being bubbled into the bottle. In this case, we can see that it is rising up and dropping into the bottle. To avoid the kinking, we can see that the tubes have been hung up. So, the three tubes that are visible, one is the blood in tube, one is the waste out tube, and one is the ozone in tube. A Velcro tourniquet is now applied to the arm. The patient is asked to pump up, close his fist tightly and ensure that the veins bulge out, and we use the largest cannula possible for the donor site. A 16 cannula is good enough, and we can see that we have already located the vein. Once the vein is adjusted, it is anchored into place, the cannula is anchored into place, we can attach a adhesive elastic bandage and ensure a free flow of blood. A gauze piece is kept below the cannula, and the cannula is now attached to the bivalve of the donor set. So, we can see the inner lining is removed and the bivalve of the set is attached. The venflon is anchored tightly. Heparin flow tube is opened and the pump can be started. Once the pump is started, the blood will start being milked out of the vein. The patient is asked to pump a ball or a sponge piece while the blood is being sucked into the donor set. We keep the speed very low to start with because we do not want the venflon to kink or collapse, vein to collapse and obstruct the venflon. Once the flow has begun, we can increase the speed. In the initial stages, as the tube has heparin priming inside it, dark blood is not visible, but once the heparin flow is adjusted and the pump speed is adjusted, we can see the dark venous blood gushing out of the vein, going through the perfusion pump and rising up to the bottle. You can see that the blood is traveling right up to the bottle. Once the stainless steel tube is immersed in the fluid, in the initial stages, the saline, we have to switch on the ozone machine and set the regulator at the desired flow to ensure that ozone starts bubbling into the solution. Here we are attempting at 100 micrograms per ml of ozone in 1/8 of a liter per minute flow speed, which means in 8 ml, in 8 minutes, 1 liter of ozone is perfused through the system and 100,000 micrograms of ozone enters the EBOO system into the patient. The foam or froth you see on the top is the coagulation of protein, and the excess waste shall come out of the needle on the top. We can adjust the speed upwards or downwards, and we have to wait till the bottle is half full before we start the transfusion. We can see that the inflow blood is not yet dark enough because of the heparin flow and is slowly getting darker and darker, but as it is being bubbled with ozone, it becomes redder and cherry red or tomato red. Ozonization oxygenates the blood, and we can see the difference in color even in this view, where the blood color from the tubing and the bottle are different. The bottle is brighter red as compared to the tubing, which is a darker venous blood. It is essential to ensure that a good vein is available so that we get good inflow. I aim at 40 ml per minute of flow, so that in 30 to 40 minutes we can get 1.2 to 1.6 liters of blood ozonized. I also aim to get 400,000 micrograms to 700,000 micrograms PPS per patient per session of ozone, depending on what we are administering EBOO for. In viral diseases, HIV positive cases and similar situations, the ozone dose administered is considerably higher. We can see the ozonization is causing the blood to become cherry red. Now is the time to get the recipient site. For recipient site, we can go even to the wrist. For donor site, it is always better to have a cubital vein because we need a larger area for the venous outflow. For recipient site, a thinner 18G venflon is more than enough. We can even go for a 20G venflon, but the outflow will be a little slower and the procedure may take a little longer. Even for inflow, an 18G venflon, green venflon can be used, but then the procedure will take about 20 minutes longer than what is being displayed here. This is a real-time procedure and no steps have been missed. The entire procedure from start to finish has been recorded. Once the recipient site has been located, we put our prime solution to flush it to ensure that it is in place and lock the venflon in position. The syringe remains anchored to the vein and we wait till 50% of the bottle fills up with blood. Once 50% fills up, we will prime the bottle, prime the transfusion set, and you can see the color of the blood which is emerging out compared to the blood that is going into the patient. We wait till the bubbles are taken away, and now the set can be attached to the recipient site after removing the syringe, and the flow can be started. One has to ensure that the inflow and outflow are balanced, and we always keep the levels of the bottle at half. You can see the inflow of venous blood is dark in color, the outflow is like almost arterial blood. You can see the difference in colors, and the foam or froth or waste is emerging from the third tubing which is going into the bottle. The whole procedure is seamless and in real time timed. We are giving ozone at 100 micrograms per ml, meaning in 32 minutes we will be administering 400,000 micrograms of EBOO, and the patient is comfortably seated. We do not make the drama of taking the patient to the ICU, connecting monitors, connecting pulse oximeters, or portraying this as an intensive care procedure. EBOO uses no drugs except for heparin and is a very comfortable and convenient procedure, safe for both the practitioner and the subject. As we are using the ultraviolet light, which is called UVBI, ultraviolet blood irradiation, it is better to use ultraviolet protective spectacles for the procedure. We wait for a desired period, in this case about 35 minutes. You can see that ozone is flowing now at the rate of 1/16 of a liter per minute. That makes it 110 micrograms per ml. As we are reaching the close of the procedure, this is our ozone generator on switch 4. Here is the oxygen in that is going into the machine. That is a perfusion pump that is drawing the blood from the patient, and the speed of the perfusion pump is 35 to 40 ml per minute. We are now about to close the procedure, so we have reduced the speed to about 26 ml per minute. Already 30 minutes of procedure has happened. The bottle is a little more than half full. It has to be retained at its level. The inflow blood is dark in color. The outflow blood is bright cherry red. The waste tube is collecting the waste, and the whole procedure is seamless and very comfortable. The 4 tubes are shown. The tube extreme left is the recipient, which is bright red. The next tube is ozone in. which is transparent, then is the waste out, which is taking out the blood, and the next one is the ozone, the blood in, which is like the venous blood, which is coming from perfusion pump, which is violetish or darker in color. This is a simple setup: oxygen cylinder, an ozone machine, a perfusion pump, a heparinized saline bottle, an ultraviolet irradiation hanging chamber, a couch, a patient, the operator. I have asked my assistant to keep recording live without any editing, and no editing has been done in this case, so that the reader or viewer can observe everything in real time. As the subject is a medical doctor himself, I am lecturing him and I am explaining to him how and what is happening. I am telling him that the blood flows in through the perfusion pump, which is sucked in like a cow being milked. It goes into the bottle, ozone comes from the top, the froth or the waste goes out to the waste tube. We are constantly monitoring the inflow and outflow levels to ensure that the bottle is kept half full. Once 35 minutes of transfusion are over, we switch off the perfusion pump. The connection to the donor venflon is removed and it is capped. At this stage, we have switched off the perfusion pump. We need to close the heparin saline. We remove the donor connection and we will speed up the pump after restarting it, so that the remaining blood in the tube rapidly goes in and it enters into the bottle. You can see the blood speeding up due to the high flow rate of the perfusion pump, and the blood is going in and the last of the blood is emptying into the EBOO flask. Once the entire blood has been emptied, we can switch off the perfusion pump. We reduce the speed of the machine and remove the tubings. The heparin saline and the inflow into the bottle are now removed and the tubings are discarded, while we retain both the ozone in and the waste out tubings. The recipient side continues to flow. So, the discarded tubings are taken away. We can still see the bright red blood flowing in. So, these tubings, including the heparin, are discarded. Here we can see the bright red blood is inflowing, and even now ozone is bubbling into the blood. This will be in excess of 400,000 micrograms. We can increase the speed of the blood flow as it is the patient's own blood. This is the froth and the waste that has come out as an excess from the machine. As it is the patient's own blood and as the inflow and outflow rates are matched, there is no question of hypovolemia or shock, and as ozone is a 100% natural molecule, there are no chances of toxicity. Literature in past has been scaring us about adequate doses. At IAOS, we have defined and redefined, relearned the correct doses, which we now have marked at 1 microgram per ml of circulating blood in the person depending on his height, weight and blood volume. An average female of about 5.2 feet height, 5 feet 2 inches height will have about 4.5 liters of blood, and for such a female 400 to 450,000 micrograms total per patient per session dose will be adequate. For a tall man, 6-footer who is bulky 75-80 kg, we will need 600 to 700,000 micrograms. Once we are reaching 1/3 of the bottle, the last stage is the ozone is switched off, the oxygen flow is switched off. We can see the tomato red or cherry red blood flowing back to the patient. The patient is very comfortable, he is feeling cheery and happy. Incidentally, this is the 8th doctor in the last 10 days and the 14th doctor in the month of March. About half of them were anesthesists, another half were orthopedic surgeons, all of them keen to learn ozone and EBOO. You can see now that we are in the closing stage, the blood is flowing at top speed. Once the level of the blood comes below the last IV lamp, we can switch off the IV lamp, allow the entire blood to flow into the subject, and the recipient set can be readjusted to ensure that the last drop of blood gets into the patient. You can see the color of the recipient blood, which is like tomato red or cherry red. The UV protective glasses are removed. The last of the blood is allowed to flow into the patient. The transfusion set is adjusted, and once the bottle is empty, we remove the transfusion set from the bottle and allow air and gravity to push the remaining blood in the tube into the patient. Not 1 ml of blood is wasted, and everything is a closed, contained, contamination free, sterile equation and situation where the uses of other accessory material is avoided. The patient is shown the empty bottle to show the bubbling of the ozone. The tubes are removed, and after the needles are taken away, the tubes are binned. The recipient tube is removed and the venflon is clamped. The procedure is now over. All that remains is the extraction or removal of both the venflon cannulas, padding it with a very tight pad and pasting an elastic bandage with specific instructions to the patient not to remove the bandage for at least 4 hours. This is because we are using anticoagulation and accidental removal of the bandage or removal of pressure where the cannula has been inserted might cause bleeding and might panic the patient. Here it is a doctor who has come with 2 of his assistants, one nurse and a clinical assistant, and hence we are not very much worried. The indications of EBOO are very large and the complete list of indications has been given in lesson 28 or 29 of this course. We have used it most commonly in diabetes, peripheral neuritis, avascular necrosis of hip, HIV, HPV, severe infections, fulminant infections, and for performance enhancement and sports persons, medical doctors, I myself take it for general well-being, improved oxygenation, detoxification, better balance of reactive oxidative species, mitochondrial health, reduction in the length of telomeres and age reversal. EBOO is a wonderful procedure and the latest IAOS Gen X EBOO system is a wonder of wonders. If you are a medical practitioner interested in ozone therapy, feel free to contact me at the above number and I shall be happy to send you the details of the course. If you are already doing the course, please ask me for the next lesson when you complete the course. And if you have not done the course and you are watching this video, you are free to message me in WhatsApp to ask me details about the course. WhatsApp messages only, as phone calls are seldom answered. Thank you very much and have a nice day. Thank you.